Hello everyone, this is Tae Kwon from Keene, New Hampshire, and this is your RIPE Global Fellowship and Implantology case review. Today I would like to share a case of Scott. Scott presented to my office needing extraction of 2 molars on the maxillary left quadrant. And before the extraction, we already discussed about options to replace these missing teeth, and Scott and restorative provider decided to proceed with implant therapy on first molar site. And before we start the extraction, I already informed him that the sinus is very close to the future implant site. You can clearly see from periapical radiograph the sinus is coronally placed or pneumatized. So our plan was to extract these 2 teeth and then let the site heal for 6 months and reassess the position of the implant, position of the sinus, and place the implant with a sinus augmentation. So this is very important to discuss this potential need for sinus lift ahead so that you don't alarm the patient or surprise the patient later in the treatment plan or later in the treatment. Furthermore, he did really not need a socket grafting because he had wide buccal and lingual width. And in case, let's say, somehow the bone really resorb to the point where we need to graft the bone horizontally, most likely I can probably combine them when he needs sinus augmentation anyway. So instead of doing 2 separate surgery where I do socket grafting and then later I do the implant placement with a sinus augmentation, which is another part of bone graft, I told him maybe if you ever need a bone graft horizontally, then we can combine that when you're doing the implant along with a sinus augmentation. So teeth were extracted, and then you can clearly see there's not much bone that is available before the tip of the crest hit the sinus. And this is how the site look after 6 months of healing. You can clearly see the floor of the sinus migrated more coronally, and remaining bone is extremely thin, or maybe 2 to 3 millimeter. Generally, if the remaining bone is less than 5 millimeter on a PA, then this is when I normally use lateral sinus augmentation approach as opposed to crestal/internal sinus lift. So this is how he looked pre-operatively, and then you can clearly see that he has nice width of buccal lingual bone. And first, I made an incision. Always, I would like to use the vertical incision on the mesial aspect of prospective windows location so that I can create nice access. And then I used a high-speed round burr, diamond round burr, just clearly and slowly outscoring the window. And the size of the window can be big or small. I always like to make the size of the window smaller, which kind of give me a little bit difficult access, but I have instruments that allow me to go into the sinus through the small window because the shank of the instruments are long. Once I outline the sinus, this is when I tap this remaining bony island that is surrounded by the outline, and then I tap this bone with mirror handle and then break into the sinus, like so. And then after that, I gently move the sinus floor using series of instruments up, up, up. And after I elevate enough, the implant is placed, and then when I'm placing the implant, I can visualize the sinus, making sure the implant does not go into the sinus. And after that, I complete the packing the bone graft. In terms of the bone graft, I pack the palatal side of implant site first, place the implant, and then finish the buccal side later. Because otherwise, if you put the implant in, how are you going to pack the bone on the palatal side when you have an implant on the way, right? So again, I graft the palatal side first, place the implant, and then buccal site. And sinus has been filled. In this particular case, I have used mostly human bone graft with a little bit of xenograft mixed. And window has been covered with a collagen membrane, which is not shown here, because the study indicated that when you actually put a membrane over the lateral sinus augmentation window, then you actually ended up getting more vital bone formation. And then after that, I closed the site with, in this case, 3/0 and 4/0 chromic suture. And this is how Scott leaves the office. And knowing that there were significant amount of sinus augmentation, I did not want to have any disturbance around the implant during the healing, so I decided to submerge the implant. 6 months later, I exposed this implant for second stage surgery. This is what we call an N-code healing abutment, which is also a scan body. I placed that. And then restoration has been completed by the restorative dentist. And you can clearly see there is good radiographic bone fill with evidence of sinus floor elevation on the periapical radiograph. So, if you like to learn how to do this sinus augmentation laterally or internally, please join me at Ripe Global Fellowship in Implantology. It's one of the modules that we're going to spend time, A, to understand when to use what approach, and 2, how to avoid complication when you're doing sinus augmentation, such as when you get a membrane perforation or if there's not much primary stability with an implant. We're going to go over all of these with you during the Fellowship in Implantology. So please join me, and otherwise I'll see you next time for your next case review.